صوت
اخبارك؟
واضح؟
واضح.
كويس. قول لي كيف ابدا البرزنتيشن.
في عندك شير سكرين صح تحت؟ الاخضر،
وين؟
مربع اخضر.
دقيقة شوي، خلني هذه. ايوه، شير سكرين.
حط عليها وحط على السلايد شو تبعك.
هيك.
ايوه، وحط سلايد شو.
نبدا ولا على مهل؟
لا لسه مشغل انا وياك لحد الان، وبعد ما هسه صافرات كمان حتطلع صوتها.
قصدي ابدا ولا بدك استنى شوي؟
لا استنى استنى. شو هاي الصفرة بدي شيلها ولا هاي ولا هاي.
طب لك فنجان المرة يا سعد.
هات يلا.
عاد والله وديت الميتنج لكذا واحد قلت لهم يحضروها. انت اللي تسجل ولا انا اسجل؟
اسجل.
الزميرة يا باقي.
شايف؟
اليوم رحت انا عبد الهادي، تعرف حطلعنا المريض خلال يومين، ما خصموا لنا شيء والله، يا دوب يا دوب 50.
مشكلة بدها تسكير.
لا تتشرب اليومين كان راح يطلعك برنامج واسطه قويه. يلا هاي الشباب، يلا باي. لينا وشوان الهديه وين القرعه؟ ولك يا اخي والله يا عكاريت انتم ما بتشتغلوا، انا مو بطلكم. لا والله انا مش قلت لكم مليون مره لا تعطوش نفسي وجهي، بيناتكم ملازقه من بعض. هذه ما ليش علاقه. قالوا عن مين؟ افرقيسي؟ يسعد الله. ليش قداكي؟ هات الزهره. والله مليح للجناين الجديده اللي مثلك. هدي يلا تزهرم. حسبي الله عليك. انا الوجه تبعك من هذا اللي تاكله. يا بعض مزبوط. والله الدنيا زمهريطه برا باقوم. ايش بدي فرتك؟ الله لا يوفقك، ما هو راسك تقول ماكينه دواليب.
ابو راشد هالزميره يا اخي طولت.
او الفوارة.
اقول هالزميره طولت.
عمر. عمر مش سامعك لك.
ولا هيك كويس الصوت.
ايه كويس، كويس.
يقول هالزامور طول يا اخي، الواحد يقول وين مخبينكم هالزمامير.
10 دقائق 10 دقائق، ما لازم 10 دقائق.
والله
عشان هيك انا بكتب انه حنبلش بعد ما يخلص البتاع ده.
عادي خلاص انت جوين. سعد كيف في تعرف انه في ناس جوينينج؟
على البارتيسيبنتس في عندنا 6 ما شاء الله. بس خليني اسال سؤال ثواني عشان نستغل الوقت بعد اذنك.
ليه؟
رامي.
انا معك.
رامي الجروم تفضل.
انا معك. لا لا لا، بس حبيت اتاكد انه في صوت وصوره.
ولا يهمك حبيبي الشعب، بس انا بس اسمع بين ما الصفرات تخلص بس بعد اذنك.
اوكي انا معك.
تسلم تسلم. طارق كنعان تفضل. من عندك الميوت يا طارق.
منيح هيك.
تفضل.
صورتي باينه؟
لا
موجود انا فيديو ولا لا؟
لا بس صوت لحد الان، بس صوت.
مبين نانسي عجرم والله يا طارق.
يا اخي مش عم تطلع من وين طلعتوا لنا في القصه انتم؟ وجع
حق علينا
الخراج.
حق علينا طور الضاني. يا الله، السلام عليكم جميعا. ان شاء الله تكون خلصت الصفارات اليوم. نرحب فيكم جميعا ويسلموا ايديكم على اللي قدروا يشاركونا واللي ان شاء الله يلحقونا بعدين. معنا اليوم الدكتور محمد فوارة. He's an orthopedic surgeon, spine surgeon, and he's been trained in the United States for spine, for pediatric oncology and tumors. دكتور فوارة الميكروفون معك.
تسلم، شكرا يا دكتور سعد. Thank you for this opportunity and welcome all of the guys there. We'll try to make it simple. I just want to do brainstorming with you guys to introduce. My voice is clear there. This is, I'm sorry, just brainstorming with you guys. This is a 26 years old lady. She was seen in the emergency room complaining of neck pain, numbness, and mild weakness in the right side. And this is her X-ray where, if you notice there, they're here X-ray in the upper part of the screen. And the CT scan is over there. And this is the axial imaging. And also this is another axial imaging. This is here MRI at that time. I would like to youth guys to think what management you will do, what kind of things you will do at this stage. Would you do fixation if your approach will be anterior or posterior? Would you do something different? Will you
بعد إذنك أول شيء somebody has some kind of diagnosis اللي عنده جواب بس يرفع إيده.
Yes, if anybody want to give a diagnosis, that's okay.
اللي بحب يحكي، اللي بحب يجاوب. حد له كومنتس، حد له أسئلة؟ فارق بس بعرف
Yes.
this is a destructive lesion. إذا أنا شايفه بالسيت سكان this is a destructive lesion.
Yes. I'm sorry. Yeah, this is destructive lesion is occupying most of the odontoid, maybe the left side of the C2 pedicles.
Yes.
And lateral masses. It is have intraspinal lesion. Did some axial rotation or instability. You see the MRI. There is moderate to severe stenosis over there. This is the images. This is T2 and this is T1 and this is with contrast, taken contrast, and this is the axial imaging overcoming there. So I would like my colleagues there to think about diagnosis, or if they want to do something else. And if by the end of the lecture, maybe some guy will tell us what management he will do, if he will do approach this as anterior or posterior, or even some way different than we think.
Just one question.
Yes, sir.
Do you have any lab results?
Yes, but it is not presented here now. Yes. What you need from the lab?
I would like to ask for something extreme.
Mm-hmm.
Function of parathyroid.
I think it was high.
Just that. It's okay.
Okay, thank you. Thank you, Rami.
Thank you.
Should we proceed, Abu Rashid? So our main topic today about the bone tumors, we will start just to put our agenda. We may take just one slide about myths and about the incidence. Then we will talk about management strategy. We'll talk about presentation, physical exam, imaging, medical management, surgical management, staging somehow. And we will just stop by some primary bone tumors, benign and malignant. So always when we think about spinal tumors, we should think about metastasis, because metastasis is the most common than primary. And as you all know, we have 5 most common, which is breast, lung, prostate, thyroid, renal cell carcinoma. These account more than 60 to 70%, and there's 10% of unknown. Also put in your landmark or put your differential spine infections. That also can become as a spinal tumor, and you need to think about it. The incidence of prime tumor, usually they are rare. Incidence about 0.4%. Benign usually more common. Benign usually come in the 2nd to 3rd decade, and most of the time it's in the posterior elements. Malignant tumors usually come later in age, and vertebral body mainly be involved. Sarcomas, 10 of them will arise in the spine. How we can build our management? I think we can build which we call, this is called management strategy or management pyramid. You need to establish that it's in complete history, detailed exam. You need some lab investigation, and that was very good remark from our colleague Rami. You need to do an X-ray, which is a good to start with. CT scan, MRI. Most of the time you need it with contrast. You need a biopsy, medical management. You need to think to consult your colleagues in the medical field. Surgery may be indicated, not most of the time. And you need to think about chemotherapy and radiotherapy. I like this picture because it's give you the pyramid of diagnosis, I call it. So if you get your complete history, then we will get some information. Your exam will delayed or will diminish your differential. Then you get some lab tests. It's maybe other than also X-ray, CT scan, and MRI. Bone scan is important. Nowadays they consult some people, they have PET scan instead of bone scan. Biopsy, I call it different because it's very crucial. Most of the time you need to think about biopsy all the time. And two things to think about biopsy: if you can do it, it's one thing, and if there is somebody can read it in your institution. And you need also to consider the surgery later on, how it will be done there. So don't disturb surgeon pathway later on. And then after the surgery, you may go to chemotherapy or radiotherapy and vice versa. And for biopsy, we have fine needle aspiration biopsies, can be, and core biopsy. Both of them can be done by spine surgeon or even by interventionist. Now there's a lot of medical management. They call chemotherapy, which is induction chemotherapy and adjuvant chemotherapy, and then they send the patient to the surgeon. What's the surgeon role in a spine tumor or tumors? He can do the open biopsy, he can do curettage or medical marginal excision or implant excision or radical surgery. Most of the time, I think the tumors in the spine will go as a marginal excision, because we couldn't in-block excision as per se. It's maybe not possible in spine. When we come to the presentation, maybe pain is the most common. Pain or neurological dysfunction, bony destruction, or sometimes you see neurological deficit or progressive deformity. But pain, will concentrate more on pain. Pain is the cardinal symptoms. Most of the time it's axial or radicular. It is unrelated to the activity. Acute pain indicate there is a collapse of the vertebra. Chronic slow growing, it is more with the tumors. And the alert for that is persistent pain, mainly at night, localized and early related to the activity, and even that cannot be relieved by most common analgesia that we know. Back pain is an important also, because all that we told about back pain or neck pain, the first alert is the cardinal symptoms. It's persistent, unrelated, and worse at night. This is very specific for tumor pain. Neurological symptoms that can be there, it depend whether the tumor is in upper cervical spines or in thoracic or lumbar. It can be presented with upper or lower motor neuron lesion, and all of that we need to take care of it. And sometimes if it's lower hypotonia and hyporeflexia and or incontinence or compression loss of function of the bladder. Progressive deformity occurs sometimes in quarter of the patients. It can be due to either kyphosis or scoliosis. Sometimes it's flexible, especially if it's related to the pain from the start, but later on it can be permanent or even due to destruction of the vertebra. The age is very important in the differential diagnosis. For example, if you get a young, most of the time it's either malignant or elderly metastasis, adolescents in between. So for example, if you're getting a young patient, you're thinking of malignant neuroblastoma, astrocytoma, or a sarcoma. In the adolescents, there is a lot of common osteoblastoma, osteodystoma, neurosmal bone cyst, hemangiomas, and most elderly they consider with chondrosarc and metastasis, myeloma also, and sarcomas. This is another table that showing you that from 0 to 5 there is very common eosinophilic granuloma, from 5 to 10 aneurysmal bone cyst with granulomas and osteoblastomas, 10 to 20 and it is aneurysmal bone cyst. But you also will find different pathways, or you find also some exceptions for these rules, not and fixed rules. On exam, you may find nothing in patient with a tumor. Sometimes you'll find scoliosis, or some you'll concentrate on the neurological exam. It's very important that you document your neurological exam. For example, if you look at this young lady, she was 6 years old when I saw her. I don't know if you guys appreciate, there is some kind of swelling in the back of her neck over here. At the same time, you see there is kind of torticollis to the left side, and if we remove that, the cover of the eyes, you have some kind of facial asymmetry because she has doing that for a long time. On plain X-ray, usually I would like, this is one of the board questions. Most of the time, the people jump to the MRI or CT scan. I would like to get MRI. MRI means X-ray. X-ray will get you the appearance. I know that it may not give you imaging of the destruction unless you get 50 to 30 to 50%, but it will get you some information. If you hear there is some instability, you see here in the lumbar spine there is an compression of the spine, and you see there is change of the vertebra, then this will alert you. And as we know that we find either it is lytic, blastic, or mixed, or even blastic. At the same time, the wrinkled owl sign, which is a classical sign of destruction of the pedicle, you may not find it in everyone, and you may need a very good suspicion to see it. If you see this vertebra, it's L1 destructed pedicle in the left side while it's preserved, and this is as the owl, and it is most of the time due to the malignant lesion. You see as lytic lesion, as in this in the right side and the left side, you see that there is a lytic lesion. Sometimes the X-ray that or CT scan we offered the first, it's lytic. You see there is some kind of lytic lesion here. Blastic, sometimes some tumors as renal cell carcinoma or metastatic, they give you a blastic. I mean, you see there is building of the bone, it's hyperdense, which is mean. Sometimes sclerotic or blastic. Then keratocystis repeated again, sorry. Then you just may need to do a special characteristic, or you do CT scan. You see that in the middle there is destruction lesion, the disappearance of the odontoid in this lesion. And if you see this is the same patient, and the same thing if you here see this is the other one, you see some kind of bubbling of ballooning here of the same lesion. This is good way also to think if the lesion is in the anterior part or the posterior part. And the posterior part, most of the time it is due to benign lesions, but this doesn't mean that malignant lesion can occur or extend from the anterior to the posterior part. And anterior lesion, most of the time they are metastases, myelomas, histiocytomas, chordoma, Langerhans cells, all of that coming in the anterior part. This is, you see, this is, for example, ballooning in the posterior element, and this is the same thing here, and it is here in the anterior part. This is another tumor. Location is very important from the spine, which is sometimes the spine will in the neck or something, they are in the posterior elements. They can be benign or malignant. If you see this is a diagram, that's chordoma, for example, and aneurysmal bone cyst coming for the lamina, while osteoma, it's coming around the junction of the lamina with the facet and gentile tumor, osteosarcoma, eosinophilic, all of them coming anterior location. Sometimes some of the tumors, they have predilection for specific spines. For example, the chordoma is coming either in the sacrum or the lumbar. Most of the metastasis is coming in the thoracic spines, the eosinophilic granulomas, osteochordomas, all of that. Then this diagram can give you some clue about what kind of tumors you may are dealing with. Lab test, this is again, it is a credit for our colleague Rami that you may need to ask about some lab tests, CBC, calcium level, ESR, parathyroid hormone, tumor markers, all of that give you clue which kind of metastasis or primary tumor we are dealing with. Some tumors with the imaging, they have some characteristics, imaging findings, for example, ballooning. If we see some kind of balloon like we see here in the cervical spine, this is more with aneurysmal bone cyst, and sometimes gentile tumor doing that. The chordroid or appearance in the X-ray or polka dot in the CT scan, which is come with more with hemangiomas. Some kind of stable calcifications come with cartilaginous tumors. Sometimes osteoma, you will see the needles in the CT scan. Sclerosis, rim margin, all of that give you clue about the characteristics of the lesion. Body scan will give you what kind of activity there. Nowadays, we are replacing it with PET scan, which is give you more accurate about the metastasis or about the future. For some tumors, for example, multiple myeloma will give you cold appearance in the PET scan or even in the bone scan, and this is as not usual. Followed by the other tumors will give you hot spot, others will be cold. Most of the malignant tumors will give you, or active tumors will give you active spot. CT scan, as we said, it's very important, give you the exact destruction. Like here, you see a lot of destruction, or here you see a lot of destruction. Sometimes give you the needles, as here, this is an osteoma, and you see that it's occupying it's very characteristic lesion to them. Sometimes give you the amount of the stability you get to get how you manage. The MRI, most of the time, we will take it with contrast, and some tumors has very characterized, as you see here, this is air fluid levels, which is come with for aneurysmal bone cyst, and the same way here. And you will see also the exact tumor size, soft tissue lesion, how much compromisation of the nerve, because we are dealing with the nerves, and if I will do decompression or not. Biopsy, I will just confirm again to do biopsy. If the lesion is big and you need to do a biopsy, if it's accessible and it is not harmful to the patient. This is a biopsy that was done from the same patient we offered you or we showed you in the beginning, but it was done as a minimal invasive technique. And you can do the biopsy yourself, or you send it to the interventionist. You can do it under C-arm or even under CT scan or even navigation guided. This is the institution I was working with. We have navigation, so we fixed the navigation ball over here in the thoracic spine, and we can take biopsy from the lower lumbar spine. And this is the amount of biopsy we can get even with a small incision you do. I will just confirm to biopsy. This is a guy's female nurse. She was a Filipino nurse with us. So she complained of back pain. The surgeon showed that this is a small mass. I can't chip it out. He did the primary excision of the mass and fixed the patient 2 levels up, 2 levels below. And without doing biopsy, come to malignant sarcoma, pleomorphic and differentiated. But a week later, within 1 week, you see how big the mass was doing, and the lady was complete paraplegia. And I think the guys there, they ruined the life of this patient. If they did a biopsy, then the tumor may be sensitive. She was walking to the hospital. She went back in a wheelchair, so she was walking. If you get a biopsy, do chemotherapy or some kind of radiotherapy, she may be still walking at that time. So biopsy is a very important issue. I would recommend for you guys. The special characteristics we already discussed about ballooning, corduroy, polka dots, all of that coming in some patients. You see this is hemangioma. It's very common. You have these polka dots or gel bar appearance. Ballooning, we said with that. And sometimes it is you see the patient unrelated to the complaint. So this is one of our patients. She came for scoliosis. And then the X-ray, they saw the primary surgeon so that there is some kind of stability adentic lesion over the odontoid. At that time, he thought that he take a biopsy and put a halo. I don't know if you appreciate here a halo. So he, without complete investigation of the patient, he did a halo and take a biopsy and throw some bone graft over here. So I'm sorry for that, but this is what our colleagues did. Then he referred the patient to us for further management. So this is a patient with neck pain. You see that there is some kind of instability here. And this is another one, ballooning. We already appreciated that. So if you the X-ray, we said you know the location, some characteristics. You may be in the body or your expense side. You see specific characteristics. Then you have some kind of clue for your diagnosis. Bone scan, we already talked about that. And CT scan, we already mentioned how much destruction and the needles. I'm certain some of the slides were. At the same time, CT scan will help you to follow up your patient. You see that this patient has a lot of destruction over here. Then we treated her conservatively and followed up over here. You see that good fusion. At the same time, you see how much ballooning over here, how much destruction in the thoracic spine. MRI, very important. Usually, tell you the exact. Some people or some tumors like chordomas, usually characteristic appearance in the MRI. And we said also about air fluid levels, and the disc biopsy is essential. You need to do that all the time. And this is the same patient, we already talked about it. Open biopsy, sometimes you don't get a diagnosis. You see the open biopsy. This is the same lady we offered the young patient. We did her curettage, and the diagnosis was come to be aneurysmal bone cyst of the cervical spine. So we did her fusion and the curettage. I don't know if you see here when we curate, we were able to see or take part, even reach anterior from behind as much as we need to fix that. Biopsy, we already communicated with that, and this is the same patient without a biopsy and biopsy. Now, staging is a very important issue. Staging has different, staging is a mode of communication between surgeons. At the same time, give you how much the tumor is extending. So you need to, which is tumor stage, you need to do distant metastasis or regional or lymph nodes. The most important is distant metastasis. This will upgrade your grade. So you are looking through physical exam, X-ray, CT scan. Nowadays, they do the PET scans, give you the best modality of staging. And for benign tumors, they can be diagnosed or staged as stage 1, which is inactive, or stage 2, which is active, latent, and stage 3, which is aggressive like giant cell tumor, and which is called Incan classification. We have also for malignant tumors or Steve Boriani, which is taking the about 10 or 12 zones around the clock for the spine. Then it is A, B, C, D. For example, he's starting from the left side 1, 2, 3, 4, 5, 6. So this is one zone. Then another A, B, C, D according to the nearest approximate one. For example, A in the soft tissue, B in the spinous process, and D in the dura, and E in the spinal cord, and C around in the peculiar space. So all of that will give you a grade, exact grade. I think to meet a classification here, take a different part about how much extending from the body. Then he gives about 6 subtypes, and there is another modification from to meet stage. They are modified it. Then they get you how much prognosis you get from this, because not every patient you get from the medical say, okay, do operate in this, you will operate, because you need to see how much prognosis you have. And there is another Tukahushi, which is more advanced, and it's giving you give you credit for each. For example, in general condition, you get poor, moderate, and good. And this one giving a score from 0, 1, or 2. How many metastases of the bone you get it. If it is more than 3, you get 0, less than 2, 1, and 0. Then you give you credit and number of extraspinal metastases. Then you collect your scores. If the patient from 0 to 8, then his survival may be less than 6 months. From 9 to 11, more than 6 months. If he more than 12, he may reach 1 year of survival. Now, when we go to the management of the spinal tumor, you need to know chemotherapy sometimes is indicated, especially in osteosarcoma. So when you get your biopsy, your medical oncologist, they will tell you if this is chemo sensitive or radio sensitive, or it is only surgery sensitive. So for surgery, usually we get marginal excision, wide local excision, or intra-region. Most of the time, we get marginal excision in the spine. The pathology of the tumors, sometimes you may need to do some embolization, especially in the vascular, highly vascular tumors. This will shrink the tumor, give you more chances to decrease the bleeding. At the same time, it will help you in your surgery. And then also, you need to know your approaches, anterior, posterior, or you combine. You need to know your instruments. You need to know the people around you. They can manage that, or they will not help you in that. As we said, the tumors, they can be radiosensitive or chemotherapy. They decrease, shrink the size, and make it easier for you to diagnose. Is the tumor, say, radiosensitive or chemosensitive? Is very important question you need to ask it. Rarely require open if they are radiosensitive or chemotherapy, as lymphoma, for example, choriocarcinoma, and hematologic tumors. All of them, they are chemosensitive or radiosensitive. Then if you give them some chemotherapy, their tumor will disappear. And this is just how do we classify them: high sensitivity to the radiotherapy, like leukemia and chemotherapy, leukemia, lymphoma, myeloma, plasmacytoma, and there's a low, like low renal cell carcinoma, thyroid, and colon. All of these, they are not moderate, breast and prostate. Nowadays, they give radiotherapy for most of the tumors if they are not doing surgery for them. Sensitive to the chemo, you have as osteosarcoma, immune sarcoma, lymphoma, and surgery mainly as in chondrosarcoma. Usually it's not sensitive to the surgery, chemotherapy, or radiotherapy. Surgery, as we said, as a chondrosarcoma. There's a lot of indications. Some people will lay indication for radiation as a primary, or chemo as a primary, or primary surgery. I would think that retropulsed fragment in the canal with weakness, it's an indication of primary surgery. Spinal deformity, that the patient will get some the main indication for surgery will be, which is acute, as in there's a neurological compromisation or retropulsed fragment, instability, and pain that not responding to the chemotherapy or to the medication. For example, this lady, we operated him about 2 weeks ago. She has metastasis, but it's not private. Also, she has retrofragment, pulsed fragment, and she developed weakness. So we did some hair decompression and fusion, 2 levels up and 1 level, 2 levels down. As we said, embolization is a very important tool to think about it. If you have a good interventional radiologist that can help you, especially in renal cell carcinoma, because they are very vascular. Sometimes in aneurysmal bone cyst, they are very good, or even in giant cell tumor. Chemotherapy, there's different kinds of chemotherapy. I don't think they are under our control. They are under control of our chemotherapist or a medical oncologist. A lot of agents, most of them adriamycin and isofosfamide. This is for bone tumors, but it's different from, especially if there is a secondary. And as you said, this is to make you appreciate the benefit of the chemotherapy. You see how much big mass this is compromising the nerves. And this is about when they start chemotherapy, and this is at the final end of the chemotherapy. Even almost you don't see any tumor there. Surgery, as we said, for benign tumors, most of them, they need surgery for biopsy or stability or neurological decompression. And this is, as we said, the curettage. You remove the tumor in a piecemeal and then you curettage it, put some kind of bone graft. If this is unstable, you may need to fix it. This is one of my patients. She has aneurysma. She has a giant cell tumor in the dentoid, the one we show you with scoliosis. So we have to take this out for prevent it through retromandibular approach. We did that, and we fix it with a plate, and we removed the odontoid, and we put a kind of fibular graft. And then posterior, we did that. This is coming done in the same week. And then sometimes this guy, you need to remove the tumor. This guy was with wing sarcoma, and he has the only needles left. It was in I think T4, 2, 3, 4, 5, 22, and we did it completely excision from, and it was fused anterior and posterior incision. Sometimes you need to do debulking if the patient non-curative, but he has severe pain or severe weakness. You mean just debulk the tumor and do jump decompression. A lot of benign tumors, there's a big list of them. You can know them or read them by yourself. We just follow up a lot of malignant lesions there. But I mean, that was the aim of the lecture, to get some guidelines, but we will just talk about them. Primary bone tumors, we said all of them. This is, for example, osteodystroma at the primary, aneurysmal bone cyst, like this one, and eosinophilic granuloma, giant cell tumor, hemangiomas, brown tumor. Also mentioned, this is just to make you know that aneurysmal bone cyst, very characteristics MRI findings, air fluid levels. For example, this is coming in 3 years old patient with back pain, and you see almost the vertebra plana, and the pathology, or we did a biopsy, and it was Langerhans cells, eosinophilic granuloma. Osteodystroma is very common in bone, and also it can come in the spine, and it is very characteristic pain that responding to non-steroidal, and this is, you see that the CT scan, and this is the cervical spine, and it can also compromise the spine also. Osteochondroma is very common. You can see it in the spinous process mainly, but it can come through even inside the vertebral canal, and you may need to remove it most of the time. And this is in the spinous process. Aneurysmal bone cysts usually come in the young population, and you can even notice the X-ray with good reading that there is a ballooning of the spine, and this is the CT scan and MRI of the same patient. And this is how we did the surgery for the patient with curettage and aneurysm. Giant cell tumor, it is mainly in the 20s, but it can come early. And this is the same patient we talk about it. And you see it was mixed appearance in T1, T2, and you see how much destruction over there. And we did it in the anterior, and this is the final image. You see how much fusion we get here and here. And the patient, 1 year later, she did her scoliosis surgery, eosinophilic granuloma, already talked about it. You see a lot of destruction come in young population in toddlers. And you see this is the MRI finding. Hemangioma is a very common, it's one of the most common tumors of the spine. Most of the time you don't do surgery for it, but you may need this. One of my patients, he developed weakness, spasticity because of the hemangioma, and after embolization and curettage, he improved. And you see that how much it's causes mass effect over there. And it was, you see how much compression over the spinous, how much amount of stenosis over there. And we come back to our case before. I think this is the same case we did. As we said, the treatment, we can do this and this. Primary malignant tumors, we will not go deep in them, but they are very rare, but you need to think of them. They are solitary chordomas, osteosarcomas, or Ewing, one of the most common lymphomas and malignant fibrous osteocytomas. And this is, for example, most of the time treatment, you need to do biopsy, stabilize the patient, and most of the treatment will be about medical oncology, except the chondrosarcoma, you may need to do surgery earlier than you think. And we come back to our case before. So Dr. Saad, I come to the end of my lecture. So this is the case that we were discussing before. If you want to do more discussion about the case.
Thank you, Muhammad, for your comprehensive talk. I think you were slightly fast.
Fast. Oh, you can't stop me, man.
But it was really, really appreciative. I don't know, plasmacytoma, we see it a lot recently. Do you have any comment on that?
Well, yeah, I think, I think we recently, because awareness of that, because most of the time when kid or small little boy complaining of back pain, nobody will pay attention, just analgesia and send them back home. I think if you're imaging more patient, you can get it more, actually. You mean the eosinophilic granuloma? I don't know why. I don't have an explanation, but it is, you need to pay attention to this. If you do a simple X-ray on the lateral side, you can diagnose it, actually. Most of the time it's come with vertebral plana. I think about 3 weeks ago, one guy consulted me about his pain. I mean, his son was in the Islamic hospital. With that, he sent me the images. It's typical, he's a 4 years old or 5 with vertebra plana compromising his back. The imaging is typical. I didn't do a biopsy. He didn't come to me. I don't know where he went, but this has come as plasma cell cytoma. Saad. I didn't hear you, Saad. Saad. No voice.
هيك؟
سامع.
اوكي. عندنا السؤال من دكتور فراس الحسبان. What are the types of aggressive hemangioma?
Well, there is a lot of types, actually. I don't elaborate them in my mind now, but you can. Aggressive hemangioma, you mean? The question?
The question is, what are the types of aggressive hemangioma? دكتور فراس إذا بتحب نحطك على بالهاي.
I think there's some kind of aggressive hemangioma when you see a lot of vasculature about it. Sometimes it's soft tissue mass that compromising the nerves if you want to do that. But if you want to elaborate, it's okay. What he think about them, it's okay. Do you want to talk about them, Firas? Unmute, Firas.
Please mute yourselves. اللي نسمح له يعمل unmute. راس رامي وطارق.
الو.
ايوه طارق تفضل.
لا بس يجاوب فراس ما في مشكله.
فراس لسه mute. فراس unmute yourself.
Muhammad, really it was a very enjoyable lecture and comprehensive. But I have to agree with Saad. We did enjoy the images enough because you were a little bit fast. It was the images that you have collected are really, really amazing.
Thank you. Well, I was thinking he can hold my brakes if he would like to. You need to notify me.
And I wanted to ask you something about the prognosis of spine metastasis. It's different than the original tumor or cancer, as we know. And what's your opinion about this?
والله يا طارق يعني I think in the spine metastasis, the primary or the prognosis depends mainly on the primary diagnosis. This is one first. But if you have more than one metastasis, for example, last week or the 2 weeks before, they called us for a guy, and he has fracture dislocation of the spine, C7. I don't know if I talked to you, Saad, about it. Yeah, and he have destructive lesion C5, C6, C7. And his power is almost 1. They said he has a prognosis to live more than 1 year. I visit the patient. He's cachectic. In neurology, almost 1 at one side, 1/5, while in the right side weak, in the left side he is good. When you uncover the patient, you don't see his abdomen. You can't touch his spine. And they said he's a good prognosis. So, you know, they keep pushing. We did a surgery for him. We did him anterior, and then we said there should we go with posterior because of the junctional area. He's still in ventilator. I think you need to be cautious with them, because if there is more metastasis, the patient is not well healed, the primary tumor is not well controlled, more than 3 metastases, or even he is getting weak, I think it's a bad prognosis. So I read the chart.
Yeah, absolutely. But what I meant, let me rephrase the remark. The prognosis of surgical decompression of a spine metastasis is definitely better than the prognosis of the disease itself. This is the point. I mean,
yes.
Yeah. If you get patients sometimes in the acute stage of paraplegia, they are salvageable regardless of the original cancer. I mean, salvageable regarding the paraplegia, of course. And I'm sure that you have encountered this. That was actually a bad example that you have given.
Yes.
A cachectic patient, probably terminal.
Yeah, I agree, but can I reformat my example? There is another guy, he has metastatic osteosarcoma. He get weakness, and we did it for him, and he has a paraspinal mass. And then we decompress him. Now, before his wound healed, he get his mass grow again and block his spine. Would you go again?
There are many factors to be considered here.
No, he looks a good health, okay. But
I would.
Yeah, you would,
yes.
Within 2 weeks you go back.
Yeah, I would go back. It's different from, for example, an old, cachectic terminal patient.
Yes.
Yeah, it has many factors to play. I mean.
No, but my talk to you, Dr. Tariq, he is in before your wound is healed, he accumulate another mass that blocking his.
I would go again and decompress.
Okay,
yes.
But so because they didn't give him another modality.
A little bit heroic, but as you described, that he improved simply after the first surgery, I would go again and decompress. I'm not telling that not doing anything is a wrong answer, but you have options, and simply we have general rules. That's true, but sometimes you have to go by your instinct and deal with each patient as a separate entity.
I agree. I will not say no for anybody unless I saw him that he is
exactly
completely a mess. رامي
دكتور
يس
رامي الأحمر
رامي تفضل.
Okay, both of us, we are here.
Okay. Any questions?
بلش انت
Yeah, okay. My question was regarding the radiochemotherapy. What do you think about the sandwich technique, which means radiotherapy or chemotherapy before surgery, then to give again radio or chemotherapy?
Yeah, I think this is the modern management of tumors. Actually, when we were dealing with tumors, and for example, they do, for example, when they diagnose the case, they send it for the medical oncology. They do adjuvant chemotherapy, and then I think it was 4 cycles of chemo, then they send the patient back to the surgeon. So he remove the tumor or do whatever he wants. Then after the wound is healed for a couple of weeks or 3 weeks, then we send the patient back to the oncologist to do another chemotherapy, which is, I don't mind it, and I think it is a good technique to do.
Yeah, me too. I think this is a good technique and will give you time to make your decision regarding the surgery, and will you give you the time for the patient, especially in cases that they are cachectic or they are not well prepared for surgery.
Mm-hmm.
So by doing this, you gain time.
Yeah, I will do that unless the tumor is not radio or chemosensitive as chondrosarcoma, for example.
Yeah.
I didn't put the picture here, but we have a patient with big, they said it is chondrosarcoma. It is around his back, lower spine, which is, I don't think they said it is not chemosensitive, not radiosensitive. But you know, for example, I just joined the King Hussein Center here. Even if the patient, the tumor is radio resistant, if you said you will not do surgery, they will give him radiotherapy. They said they can change the dose, the directions, or all of that. They can give him some radiotherapy.
دكتور محمد رامي الأحمر رامي الثاني أنا
أهلا وسهلا.
أنا spine rehabilitation. We are dealing with a lot of recently. شكرا أول شيء للcomprehensive summarization ليور talk. We are dealing a lot of non-traumatic spinal cord injury recently. شو البروتوكول اللي أنت كسيرجن بتفضل تستخدمه من ناحية الستيرويد الديكساميثازون؟ يعني حكيت على الكيموثيرابي، حكيت على الراديوثيرابي، بس initially شو البروتوكول وكم بتفضل إنه يضل موجود، خاصة إنه بالميتس sometimes the advice إنه ينحطوا.
Well, I don't have my own protocol, to be honest with you, Dr. Ryan, but I don't mind it. يعني if I get, if I know the diagnosis, for example, if the patient known as diagnosed, for example, metastatic lung cancer, and he get weakness, I will use the steroid. Usually I use them for a couple of days, then I tapering them gradually. But for example, if you don't have diagnosis as primary, because for example, lymphoma, if you give them steroids, this will disturb your diagnosis. And if you give them steroids before you take a biopsy, sometimes the cells will faint out and you will not have a diagnosis. So if I'm knowing the diagnosis, I don't mind to giving them.
طيب هو في ناس ببلش مثلا بيعطي مثلا ديكساميثازون لودينج دوز 16 ملغ او في ناس بيعطي 100 ملغ. هذا الحكي في حال انه كان كانسر مش برايمري ميتس سوري، كان لو ميتس. بتفضل انت الهاي دوز وبعدين التيبر ولا بتفضل الاقل؟
لا والله انا عاده نعطي هاي دوز. والله
هاي دوز. شكرا.
فراس اختفى يا سعد، ما كان بده يحكي.
الله يمسيكم بالخير دكتور محمد. Thank you very much for this really nice lecture for definition in the primary tumors and also the nice cases that you are already presenting.
Thank you.
Because my question was about hemangioma, because you know very rarely we see an epithelioid in very aggressive hemangioma, and usually when you have aggressive hemangioma as hemangioma as your case, usually the compression from anterior, and sometimes posterior decompression only is not enough. So did you do any biopsy in your case with the hemangioma?
Yes, we had this case was done for us when we were in King Fahd Medical City. Everything is going to them. I mean to the high. I agree with you. If it is, you know, why we went posterior in this case. If you see the MRI, there was a lot of paraspinal tissue, and I mean inside the canal. It's a lot of hemangioma. We were not thinking that it's really the hemangioma is the main cause. So there was a doubt. So we went there when the patient get supine. When we do the fixation and we took a biopsy, core biopsy from the spine, a lot of blood coming out the paraspinal tissue. I mean the intraspinal part of it. We send it to the pathology. It came that it is hemangioma, and And actually, this case was published actually online, and they said that it was epithelial, a lot of blood-filled spaces that's coming with hemangioma. I followed actually that guy for 1 year, then I left. I didn't have any follow-up more than 1 year.
Excellent. Because I have one of the cases that it was after the biopsy, it was epithelioid hemangioma. There is 4 types of hemangiomas, and this is only really rare. And the problem that it's a slow progression. So sometimes you have to go from anterior to remove all the body, even in a hemangioma, but it's very rare. The second question of mine: what about the classification, surgical classification? How do you plan for your tumor?
How, I mean, you mean primary tumors or what?
Yes.
Yeah,
Primary.
it is, if it is malignant, definitely it will need surgery, actually. I usually plan my cases depend, which is what my role was going for, just biopsy, for example, or decompression, or there is instability. So most of the time, if I can get, for example, most of the benign tumors, I don't do fixation for them because I think we can chop them out. It's depending which modality you have or which tools you have. For example, we did a big مثلا قول معي اللي هي مش osteoblastoma was in lumbar spine. That time we have this navigation tool, the CR, the OR inside the OR. So we were able to put our cells with a small incision and we just inoculate it outside. So we didn't fix. You see that, for example, this small young lady, the one with, I show you guys with the aneurysmal bone cyst. The cyst was so big and she has mild torticollis, and we couldn't remove the cyst without doing instability of the spine. So we decided to curettage and stabilize the patient. At the same time, if you pay attention to the images, we sent here to the interventionist. He said he did some embolization and he did catheterization of the vertebral artery. So I don't know if it is, if you guys let me go back. It is, you see, it is visible there when you see, yeah, this lady. So we fixed her spine because the lesion was big, and so it's been on the size, the stability, and the diagnosis, and your aim, which was for decompression or just stability or to cure. For example, this lady, she was young, she had destruction anterior and posterior. So we aim to complete removal of this. And so we did the anterior approach and the posterior approach, and we get 360 degrees fusion. Let me just show you that. Yes, this one. No, this one, for example, yeah, this one, this lady. You see here, don't know if it's clear. If you see under my probe here, you see there is, this one is the vertebral artery stented. I don't know if this has answered all of your question or you need to add more. For example,
yes, it's a party, but you know, my question that you questioned again, Dr. Tariq, about to go again for the tumor or not. These are the prognostic factors that we want to know. Do you really rely in these classification that already mentioned?
Yeah, well, that's a good point. I don't, you know, I don't know if you went, for example, in the Western country, MD Anderson, if they said the patient has 6 months of survival, a lot of surgeons will hesitate. They said it needs at least more than 6 months of survival. But usually I go to this. If the patient has no much major metastasis, patient looks good. He, for example, the lesion gives him sudden weakness, as Dr. Tariq said. For example, it's depending if the patient didn't walk for a month, while he yesterday was walking today, he is not walking. If, for example, did a major disturbance to his bowel or bladder function, that will hit you more. Depending on which kind of insurance he has. If the patient in public institution and he may pay nothing, why not to go? You see, I put all of that in my face, then I will decide. Most of the time, I will not hesitate. I said to do most of these cases because If the patient will paying nothing, the government is covering him, he can benefit at least if he has 6 months to survival. I will go, anybody above 3 months, I may do surgery. If it is simple, for example, if you need a major reconstruction, anterior, posterior, then no, I need 6 months of survival to go in.
Okay, and the last question, please, about the radiotherapy, and what do you think about the combined treatment of radiotherapy, which is the resection treatment of the tumor with radiotherapy, the new technique or management of the spine tumors, especially the primary, that radiosensitive, and the second one, when you do the surgery after radiotherapy?
Well, that's a good question for us. First of all, I would like to get at least 4 weeks post radiotherapy if the tumor is not growing fast, because when you cut through the radiated tissue, it's very tough and the healing will be very bad. The other way, I would like to wait till my wound close to give them to the radiotherapist. This is why we get this patient, he is still not doing radiotherapy and the wound is not well healed and he still get that. I think radiotherapy is a good modality to use, but if I have to do both, I would like to go first, because I will get fresh tissue, I can close it, I know my dimensions, good skin to close, good muscles to deal with. I don't know if you go after radiated skin or radiated muscles, it's a heck, man, it is very tough to go through.
Okay. Thank you very much, Mohammed.
I would like to ask.
Thank you for the answer.
Last question. Is anybody applying the scoring system we learned? And if yes, which scoring system?
Well, for myself, I use, most of the time I use this score, but the issue that here they do conference meeting, which is multidisciplinary committee, they didn't agree with that. Most of the time, if the medicine said, okay, this patient survival more than 6 months, then you are stuck with the patient. It is not your decision by yourself. It is a committee decision. I don't know about Firas, if you do with or Saad.
Look, without classification is for me very important, just to guide you in general. So if we are talking about even or Tomita or Tokuhashi classification,
or SIN.
What please?
SIN.
Yes, Tomita is not same.
That's
like
no. Spinal instability neoplastic score. It's the newest one.
Okay, the same. Even I told you, even the same. If you have other classification, there is evidence papers that conclusion over this classification is about 85% success. So 85% is not. It's really good in our surgical planning. So I believe that you have to follow some classification. And as Dr. Mohammed said, there is other factors. The other factors is, the socioeconomic status, how the patient, how much the patient can afford the treatment financial-wise, or how can he cooperate with you with the protocol of the treatment. So I believe that classification is very important, and to study the socioeconomic status of the patient also is very important regarding insurance or not insured, and how much he can be cooperative with this. This is for the classification, and this is that usually I do in my practice.
Okay. Any other comments? Can Rami comment on this case? He said he need, I know, parathyroid hormone, or Rami, are you still with us? Brown. Yeah. Actually, that was a good catch from Rami. I didn't have the images here, but when we did the MRI, there was, you know, a hot spot near the parathyroid. And then we pay attention to the parathyroid function, and we did it, and definitely the parathyroid hormone was high, calcium phosphate was low, calcium normal. And we consult our colleagues, which is the general surgeon. He said, okay, this can be parathyroid, it need to come out. So he took, you know, standard spinal, neck approach, and I said, okay, can we, the question, would you take this as enough for you to diagnose it, or would you do something else, Rami?
But I will take the risk and I will wait.
Okay. So because the surgeon already there, so we said, okay, we can stick the Jamshidi needle in the, you know, in the same, it is the, already he isolated the carotid out and the spine in front of us. I said, okay, we'll just stick a needle and take a biopsy. And the biopsy came as fibrous tissue consistent with a brown tumor. So this is what we did. We give her a neck collar and we followed up here. And this is her serial follow-ups. You see that how much she was here, and you see how much calcification she was here. And I have a pictures, a clinical picture of her, but I don't have them here. She was very happy. Although you see with some rotation instability of the C1, C2 instability, but we said, okay, she can tolerate that instead of a major surgery of doing this. And this is how she went with. And this is her MRI. You see how much the improvement, there was no more. You remember the stenosis before? It's already gone. And this is our conclusions. Always consider biopsy, guys. And always consult colleagues, chemotherapy, radiotherapy, guys, embolization. Ask, if you don't do anything, ask your interventionist to do it. And if you have extra tools like intraoperative monitoring, navigation is a good tools in your hand.
يسلم ايديك. شكرا يا دكتور محمد، بدعت.
الله يسعدك.
But there is nothing called emergency surgery in spinal tumors.
Unless compression.
Unless compression, that's a neurological, progressive neurological deficit.
Yeah.
That's right. But
Yeah,
otherwise,
otherwise no, because I think you need to take your time. I mean, even if I have a patient with weakness, but if the weakness is not complete paraplegia, I will wait till I get him investigation.
exactly.
Yes.
And the other thing, once you think it is radiosensitive or chemosensitive, start with that. That's my opinion.
I agree on that.
Start with that. Yes. Yeah, we agree. You mean send them to the other guys to do their job?
Yes.
Yes. Even if it is a private and you will get a lot of money, then send it there.
This is the right way of doing it. Thank you, Dr. Muhammad. This was very nice of you. Just a reminder, I'll send for everybody the invitation for our webinar, combined webinar tomorrow with our fellows from Egypt, our colleagues from Egypt. Dr. Faraz Hospan gratefully is participating. It will be about revision in spine surgery. And we have at least 4 talks, one from France, 2 from Egypt, and 1 from Jordan. Please join us tomorrow. It will not be on the Zoom. I'll send you the link and hope to see you all there. Thank you very much and stay safe.
نوت انا ارسلتهم قال كانهم لازم يرسلوا لك شيء، يعني ما رجعوا يرسلوا على الايميل ترى.
لا هلا لازم يبعثوا، هم لازم يبعثوا عشان يقولوا اكسبتد.
ايه لانه انا ارسلت لهم قال لازم نرسل لك على الايميل، لحد الان ما جاني ايميل. فيو نيد تو بي اتنشن تو ذات، فاذا ما لقيت حد منا حاضر معناته ما جاني الاكسبتنس اوف ذا ريجستريشن. صوتك راح سعد، ما في صوت.
طيب ليش ما الدكتور سعد يعمل لنا زي هون يحط لينك زي ما عمل؟
انا سجلت
لانه هي از ذا اونر، هناك ممكن هو مش الاونر.
لا هناك تابع لهم الابلكيشن، فعشان هيك بس انا سجلت فيه وعادي اجتني رساله مباشره بعد ما سجلت.
والله ما اجتني يا سعد، انا صار لي كذا يوم اتابع.
انا هلا ببعث لك اللينك if there is any problem send me immediately I will see what can I do. شكرا للجميع.
شكرا لك دكتور سعد وللدكتور محمد.
شكرا انتراكشن يا شباب. وشكرا للنوت اني سريع بس لازم وقفتني يا سعد.
شكرا لكم، شكرا.
يعطيكم العافيه.
هلا هلا مع السلامه.